those of you who didn't hear, Amber just said good luck as she walked past me. She and I had a little bit of a back and forth about what we were going to do for this session. She was like, I want you to talk about some stuff, and like there's problems, and I want you to deal with that. And I was like, okay. And we weren't exactly at her stage, so she made that video. And so she's like, go fix that. Go, there you go. So this is my entire presentation. It's one slide. It's just for us to kind of pull out a couple of the points from the video and begin a discussion about it. It's not formally a panel. We'll have one after this, but I am going to very much welcome participation. I think essentially what's going on here is that Amber and the community have identified things that we as a medical community are failing you all on. And I don't have the answers for that. I can talk about my approach to some of these types of issues and how we can think about it from a medical community, but I'm not going to pretend like I have all the answers. And I think, again, this is the start of a discussion. Eye movements. So actually the Maxwell video was probably like my first visit with Maxwell. I saw that video and Amber was like, so what the hell is this? And I was like, I don't know. We did an EEG and we actually weren't convinced. And I want to be clear, you can see eye movements that are parts of seizures. You can absolutely have similar looking stuff that is a seizure. And I think it is appropriate and reasonable to get an EEG and try to capture those events. And if they line up, treat them like a seizure. And what I mean by if they line up is, we've alluded to it a few times, Dr. Greenspan just talked about it, there's lots of bursts of abnormal activity on most patients' EEGs with SLC6A1. Not all, and not throughout lifespan, but for many there are, particularly in the toddler and early school age periods of time. So these bursts are happening, and those bursts might happen, and those are not necessarily seizures, but they might be. But they may be happening hundreds of times an hour. We're also seeing these eye movements that are happening all the time. So then we're trying to look at this as an EEG doc and say like, well, are those eye things happening at the same time as those bursts are happening on the EEG? And if we think, yeah, those correlate together, then we're like, yeah, those are seizures. And if they're like offset and they're not happening at the same time, we're like, nope, those aren't seizures. I don't know. Like, again, we're failing you. Make it more complicated. A decent number of patients who we've said, nope, those probably aren't seizures, have then been put on a seizure medication and those eye things have gotten better. We're using the tools we have available for us at this point in time. They're not perfect. The conclusion I've come to, and I'll also add one more caveat, if they're not seizures, what are they? They're probably stereotypies. That's the best term I think we have available to us. Stereotypies are just repetitive, abnormal movements. So, can we all agree they're abnormal? Yes. The eye movements are not normal. They are abnormal things that are happening. They may or may not benefit from seizure medications. And even if they're not seizures, seizure meds can help with movement disorders sometimes. They can help with stereotypies. If they are causing problems, they are disrupting function and that child's ability to do what they need to do, participate in school, learn therapies, all the stuff that needs to happen, you can try things, whether they're seizures or not. That's where I've gotten to. Other docs in the room, other families, opinions? We're getting some nods from table of clinicians over here. You treat them, they get better. Yeah, I think that's fair. Anybody else?
Our neurologist has called them discharges. Like, never wanted, I went to 5 or 6 neurologists, and no one wanted to say it was a seizure.
Yeah.
I don't understand. Over on seizure medicine are like 8, it's 1 to try, and they're all very degrees of success
Yeah.
on seizure medicine.
And I think that that's part of the challenge also. There's a hesitancy to say we should do seizure meds when we're not confident that they're seizures, because seizure meds have downsides to them, right? You can get side effects from them. I mean, you certainly have to always balance the side effects with what you're trying to accomplish. If you're not accomplishing that or you're causing side effects, you got to move on. You got to try something different. I wish I could say, this is it. You do this and it'll work, but it's a bit of trial and error.
So basically, correlation of eye movement to absence.
I don't know that I've seen that analysis. I'm looking at some of my friends who have also done types where we've tried to say, are you more likely to have the eye fluttering if you have absence seizures? Yes, absence seizures are the most common type of seizures, so we see them a lot, but I don't know if we're only seeing eye fluttering in individuals with absence seizures. We haven't had a diagnosis code for eye fluttering. Like, we're kind of capturing it off the cuff.
We didn't count. So for when we were looking at, we were only counting like diagnosis in the chart. So we weren't, unless you really go in each chart and read whether someone was having absence seizures versus the diagnosis I give is involuntary movements or involuntary eye movements or abnormal eye movements. So even within myself, I'm probably not doing it the same every time. And just to the point that you were making, I try to be very clear if I can. If I'm not calling something a seizure, then I say it's not a seizure, and I may say I'm not sure what it is. It's probably a stereotypy or behavioral. I don't like that word. And then you still say, well, we try a med, and I think like Scott said, if it's not bothering, leave it alone. If it's interfering, try something. If the treatment makes it worse, take it off. But I think it is very important for our families to be very clear. If I'm not calling something a seizure, then I say this is not a seizure, but we're going to still try because it's interfering. But we have not. That'll be something interesting to do in the future, to go in the chart and see who is having the abnormal eye movements that are not correlating on EEG, because that we don't have.
I'm an epilepsy doc as well for the families in the room. And what I'll say is I think this concept, your first bullet point, is so well timed, as we heard about the disease concept model study where we listen to families who say the blinking, the looking at the hands. I wasn't asking people that in clinic, And it dovetails well with this idea of what can we learn from the UT NHS and incorporate into the UCB NHS, and what are the things we wish we were asking from the beginning, right? Do you or have you noticed your loved one have these abnormal blinking events? Have they been captured on EEG? Or, like maybe some families, we've had a bajillion EEGs and they were the 2 seconds he didn't do it, or whatever. So we can kind of parse that out. And to your point about are these mini atypical absences, from the kids I've seen, they really don't, like as an epileptologist who we do a lot of absences, you look at them and you're like, it would be hard for me to bet anything I cared about that's an absence. I know it's abnormal, but it's not behaving like an absence seizure in the same way. And so I think what can feel like to families like nobody knows, the docs won't shoot me straight, which is so valid. I think the flip side is if you have a humble doc, then they're being honest about what is certain and what's not certain. And I think that's a benefit too. And so that flip is probably helpful as well.
I think that's really important. I'll just, while we're moving.
I have a quick anecdotal note.
Yeah.
My son definitely had the eye movements. They did not correlate on the EEG. They did go away with Ravicti.
Yeah. And one of the things that Zach and I were trying to do in the study is we had a number of families who had kids with eye blinking episodes, and some of them we were convinced about seizures, and some of them we were not, and we asked to count them all. And most of them got better whether they were or weren't within that specific study. Emily?
Quick question. I'm always thinking of clinical trial design because of what I do. I'm asking all the parents, does this impact your quality of life? If I cure that with gene therapy, what would you rather have, eye blinking or improvement in IQ?
The more eye fluttering, they don't learn the rest of the day. The
Okay.
And we don't understand, but we can tell you, whatever you just did is not good.
Oh, so you agree with her? So you all want
It
that
is
to go away.
disruptive.
Like we what we do when we're doing a clinical trial design is eye blinking went from 100 to 5, and that after gene therapy it went to 5, something like that.
But the behavior and IQ doesn't change with it.
You don't. Also, you think that when it improved, that the natural history is still the same. And then this is for the people who are also designing the natural history studies, right? Because if you're saying so I think those are parameters that I'd like to know as somebody who will design a clinical trial, or for whoever's designing a clinical trial. How important is it? And since Ravicti improves it, seizure medicines improve it, then regulatory people will say, well, but it's standard medication improves it. But if it does not, then am I making sense?
And it would be helpful for us to understand when it gets better, how that impacts quality of life, how that impacts functioning and abilities for those kids, because that helps us to also be able to quantify and measure that better.
I would spin it from the clinical, Dr. De Los Reyes, I would spin it from a clinical standpoint, and I would say, especially like thinking about Steve Gray's comment that these early doses have been very low because of the risk of toxicity, that if you're giving a low dose, like, how do you know if it's working just a little bit, right? Because if it's working a little bit, then you can feel better about giving more. And so you could imagine a scenario where like the eye flickering and the eye movements get better, but nothing else really does. And you're like, well, if this is a real signal, then maybe I can clinically have an instinct that giving more may have a bigger impact on some of the other endpoints more important to families.
Family comment here, and then, yes, one at the back.
So our daughter, Haley, I showed a video, I think it was like 2 years ago, maybe a year ago or something. I think it's important to note how often the eye flutters were happening. For her, it was like 90% of her waking.
time.
So visually tracking, gone. Movement, gone. ADLs, getting dressed, gone, couldn't see. Grabbing her food, couldn't see that. Socializing, how can you socialize if you're constantly blinking? So I think that more than just eye flutters, it really impacts everything, whether or not it's seizures. But we had multiple EEGs done before she was finally showing up with a seizure. And so we had EEGs that were clear despite her having eye flutters. And then we got her SLC6A1 diagnosis. And after that, surprisingly, her seizures started appearing on the EEGs. We started clopazam, and her eye flutters went away. So it's, man, if we could go back and be like, oh, we should have started on that now, or then. But she had all the seizures except grand mal, and yeah, the eye fluttering. I know it gets in the way of everything.
Yeah, I struggle with this family person is that had a lot of eye flickering for a long time, couldn't figure it out. And then I was able to record a drop seizure in my lap. And that's what really pushed it to do the extra testing on genetics. Now we're on Ravicti, stopped all that, and still seeing very slow development. And so, can you think if we caught it earlier and be able to move forward with drugs, which if you don't have the diagnosis, it's hard to get insurance to buy into those drugs. So could that have helped? But we're not seeing improvement now. So I don't have the answer, but behavioral and development delay is more important to me than the blinking of the eye. That's what we're struggling with the most.
And I just wanted to answer to the doctor's question here around the eye movements, if you could fix that. My son's been on Ravicti for a number of years, and he lost access just due to prior authorization issues, and he's back on it now, but he had to stop it suddenly, cold turkey, not our plan. It's just the way that it happened. And that was him, the first kid on the video with the eye fluttering. He had never had those prior to. He had absence type seizures. They were never confirmed on EEG. And I share that because this was a child who had never had an eye flutter before in his life, lost access to Ravicti. And just like Emily was sharing, this was 90% of his day, those eye flutters, and he would wince in pain. He would cry. I imagine his brain was on fire. And the behavior that happened as a result of that, he already has the more severe spectrum of behavior. He went to a level we didn't think was possible. We had started talking about, do we need to have him hospitalized during this time until we can get access to Ravicti? I was begging the hospital for help. Like, how do we help my son? And luckily, thank goodness to Dr. Demerest, he was able to help us get those issues straightened out. We were able to get Ravicti back, but it took a good month for him to settle down from that, and we were still feeling the effects. I was covered in bruises, scratches on my face, going to work with a black eye, weeping, bleeding from my neck from scratches. And it's my child who is the one that's suffering, not me, right? Not my family. Of course we're suffering, but he's the one paying the price. And so they're gone now, but if there were a cure for that, that would be great if we could figure that out. Would that fix the other underlying behavior? Maybe, maybe not. He has sleep challenges, but those eye movements exacerbated everything in a level we never thought possible. So I just wanted to add that as well.
Yeah, so I mean, we've had a little bit of discussion around that. I mean, certainly because of the prevalence of absence seizures, which are thought to be a thalamic cortical sort of phenomenon, that there may be some sort of thalamic thing that's happening that we don't necessarily see, or we don't see well or convincingly on EEG. But sometimes we also just see some bursts, but they're not convincing, but they also just don't line up. So I think just for families to kind of level set a bit here, we generally don't treat stereotypies. The medicines have side effects, and stereotypies are not thought to be dangerous. They're common in neurodevelopmental disorders, they're common in autism. This SLC6A1 is a bit unique compared to what else is out there. So when you're going to other doctors who aren't the doctors in this room who see a decent number of SLC6A1 patients and they're blowing you off, this is unique and different, and it's one of those rare disease challenges where we have to kind of get the word out better that there's something unique going on here. Yohei.
Yeah, just one comment from UCB. So eye fluttering is something that we are going to capture in the natural history study, and it's going to be analyzed not as the independent endpoint, but we also want to see how it is correlated to the quality of life survey and also the behavior or the development or other endpoints as well. So we are very much hopeful that at the end of the day, we would know what is the clinical significance of the eye fluttering in this context as well.